Okay. Today we have Dr. Alejandro Aguida with us. Dr. Aguida has over 18 years of experience in public health practice and research and community engagement, community-based participatory research, health education, and health literacy. She has collaborated with organizations nationally and in Latin America on capacity building efforts around program design, implementation, and evaluation. Currently, she is the Assistant Director for the Community Engagement at the Irving Institute for Clinical and Translational Research at Columbia University, Irving Medical Center. The mission of the Irving Institute Community Engagement Program is to stimulate academic community research partnerships and enhance the translation of research development in public stakeholders. Without further ado, I'm going to introduce you to Dr. Alejandra, and Dr. Alejandra will introduce her colleague, Ms. Fern Hertzberg. I may not have said that correctly, Fran, so forgive me. Dr. Alejandra will be the next voice that you hear.
Thank you so much, Dr. Phillips. Good afternoon, everyone. Pleasure to be here with you again. I'm Dr. Alejandra Aguirre. I'm the Assistant Director for the Community Engagement Core Resource at the Irving Institute. And my community partner is Ms. Fern Hertzberg, who I don't see. I think there she is. She's joining back in. Great. So I'll give her a couple of seconds to unmute herself, right, and put on her camera. Ms. Hertzberg is the Executive Director of an organization in Washington Heights called ARC 16 Fort Washington. It's an organization of 3 senior centers serving older adults 60 and above with social services, meals, enrichment, and health education. She also runs a transportation program serving Harlem, Washington Heights, Inwood, and the South Bronx. She also is very much involved in aging issues, is a co-chair of the Washington Heights Inwood Council on Aging, as well as has held numerous other leadership positions within aging coalitions and advocacy groups, excuse me. So we're happy to be here and presenting on the role of community in health research. I'll be going over community engaged research and with an emphasis on an approach to research called community-based participatory research. And then we'll actually use our current projects to illustrate this community-based participatory research approach. And then we'll open it up for questions.
I just want to make sure, can you hear me?
Yes, I can.
Okay, I can't get the video to come back on, so we'll manage without it.
Okay, fortunately, I put a picture of you, Fern.
Yes,
if you're able
and it
to
looks
see the
just
slides.
like me.
She hasn't, well, your hair is a little shorter now.
A little, not enough to matter.
All right, let's see, there we go. So you should be seeing a slide with the title Academic Community Relationships in Health Research. So this is a great illustration of how community, academic community partnerships have evolved over time in research, where initially the community was ignored. And as you see in the picture here, it's the researcher with the lab coat, not facing away from the community. And so this is very much captures the traditional relationship between researcher and human subject, right? And so they're very separate. They're not interacting other than in that one-way relationship of the researcher conducting research on a particular topic on human subjects. And then over time, it started to go into the community where research was now taking place in the community. So it was now community-based with, say, samples coming from the community. But again, community, other than continuing to be a participant in research, doesn't have any more active, meaningful role in research. And then it continued to evolve to community-informed, where it's where we're doing focus groups, we are, say, testing our questionnaires with community. But again, as the visual shows, it's still the researcher seeing, him or herself as separate from the community. The researcher is still very much in a different position, still making observations of the community residents. And so there's still this, this separation. But now we've come, over to community partnered, which has a very rich history. It certainly has gathered attention and practice over the last 10 years because of funding from the National Institutes of Health. So that funding really pushed and elevated community partnered research. And what I mean by elevated, meaning it brought it to a lot of people's attention. So the interest in community partner research, therefore, has grown tremendously. And so we've been hearing more and more about community partnered or community engaged research and community-based participatory research that I will get into next. And really here, the dynamics have changed. It has gone from the community being ignored to the community being a partner. Everyone's at the table, and it strives for equity. It strives for a shared power dynamic where now the researcher is a member of a group that is carrying out this research, is not solely leading it. And so the times, have changed, and the role of community is now acknowledged. And so one method of doing community participatory research is called community-based participatory research. And I really like this definition by the Kellogg Foundation. It is a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each brings. CBPR begins with the research topic of importance to the community and has the aim of combining knowledge and action and achieving social change to improve health outcomes and eliminate health disparities. So I really like this definition because it highlights the outcomes of social change and health equity by improving health outcomes and eliminating health disparities. And the outcomes are achievable because community plays a significant role in the research process, in the process of generating scientific knowledge that is actionable, that can be used by the community to address its own health needs that it's identified as priorities. So again, so how does CBPR facilitate social change and health equity? As I mentioned, it's because the health issue under being addressed has come from the community itself. So the community, this unit of identity, because the community has attributes that are shared by its members, has identified such issue as a priority in need of the community. CBPR, because it is it's not a research method, rather a method to do research, is very much dependent on relationships and building trust among the partners as well as between the partners and the community that's participating in the research. And so it's slow, and we have to build those relationships, and those relationships have to be based on trust and demonstrating over time that all the partners are trustworthy. Also, the findings coming out of this research are relevant to the target community. Why are they relevant? Because they've identified the issue that they want to address. And therefore, it ensures that research findings are applied to the community. So they're relevant to the community. And also CVPR fosters public support for research because it's quite a transparent approach to doing research that has taken the community's priority and focused on those priorities, and the outcome is actionable by the community. Therefore, it is an approach to research that will gain support for this type of health research. So to recap, what is community-based participatory research? It's an approach to research that recognizes community as a unit of identity. It is the meaningful involvement of stakeholders throughout the entire research process. So that moves it from community informed to community as partner, and participating from the beginning in identifying the issue at hand, in having a decision on how the topic should be researched, and what are the meaningful questions to actually ask. And therefore, what is the data that will be of greatest use to the community to be able to take action? But it's also contributing to our knowledge base, to the science. It's the relationships are based on trust. So, engaging in CVPR is not for the relationship adverse because it takes a lot of time to foster these relationships. This is more of a marathon than a dash. And partnerships are guided by a set of priorities, and it's very much action oriented because one of the outcomes is that this data be used by the community in question. So here are the principles that practitioners are guided by. So as I mentioned, CVPR recognizes community as a unit of identity. And what that means is that it recognizes that a particular community, because of its characteristics and attributes, experiences a health condition in a unique way. And therefore, we are acknowledging that unique experience, and everything that comes subsequently to that takes into account that unique experience by the community. So CVPR also builds on the strengths and resources within the community. So it's very much highlights and builds on the assets from the community, rather than seeing the community as being deficient. And so builds on the existing networks in the community. So also CVPR facilitates collaborative equitable partnerships, and that includes both in the way power is shared, the way the knowledge and experiences is valued by the different partners at the table, but also in the budgets, in the way we share and allocate money to carry out the project. It promotes co-learning and capacity building. So that's part of the action in community-based participatory research. We want to make sure that all of the partners are actually also co-learning from each other, which adds to the length of time that CVPR projects require. Because we're aware that everyone is starting off at different places. And so in order for everybody to get to the same page, it takes some time and effort. CBPR integrates and achieves a balance between research and action for the mutual benefit of all partners. So again, this one goes back to what I was saying before about striving to generate scientific knowledge as well as the data being used for social change in the community. CBPR emphasizes public health problems of local relevance. Again, ideally, this comes directly from that unit of identity, that community that we want to work with. It involves system development through a cyclical and iterative process that you'll see when we get into the description of a recent project of ours that we kept going back and forth, and we integrated these cycles into the project because we knew that we had to continue to go back to the community, to actually a couple of different communities that we were working with. So again, we allotted time and space for that. Then number 8, CBPR disseminates findings and knowledge gained to all partners and involves all partners in the dissemination process. So CBPR with this principle really pushes academicians to think about dissemination beyond the journal article, beyond the academic poster or presentation, and actually disseminate the knowledge gained or the knowledge produced to community partners so that they can use it, and to disseminate it in such a way that it is understandable and usable to the community. So again, it really challenges power structures. And 9, CBPR requires a long-term process and commitment to sustainability. So it goes back to the importance of building and continuing to foster relationships with stakeholders, and not thinking about project to project, but how will this project situate the partnership to build on itself and to go for additional funding. So with that, I will switch it over to Ms. Hertzberg to talk about the organization, and then to the first case example of a CBPR approach.
Hi, everybody. Thank you, Alejandra, for your introduction at the beginning. And then you saw I had some internet issues, but fortunately we developed the slides together. And you already spoke about ARC XVI Fort Washington and what we do for older adults in Upper Manhattan. Essentially, Central Harlem and Washington Heights and Inwood are our focus. We have done some work in the Bronx, but it is not a main focus of ours. Could we see the next slide? So ARC 16 Fort Washington, I like to call one of the biggest small CBOs in the city. And the reason we're big is that we're highly visible. Advocacy was one of the key things that our founding board of directors wanted in 1973. And it's a principle that we maintain through today. We're not going to sit by quietly and let any old thing happen to the older adults in our community. We don't believe in it. And so I had worked for ARC 16 Fort Washington actually in the 1980s, my first job out of social work school. I left to start Accessoride, and when I came back in 1999, the first thing my board of directors said, beside welcome back and please stay forever, which clearly I've done, is we want you to get onto research advisory boards at Columbia University. And you know Dr. Lantigua, who is a leading figure at Columbia School of Physicians and Surgeons. He's got a project on Center for the Active Life of Minority Elders, which are serve. And so you should sit on that advisory board. And that was the start of a very, very long, interesting pathway to becoming a researcher myself. In the 2000s, I was primarily an advisory board member. I was given a lot of information about projects that went right over my head. I thought some of the projects were interesting to the level to which I could understand them, but I was well aware that I didn't fully understand them. In 2008, the Irving Institute was awarded a CTSA grant to, as it was explained to me, translate the research that's being done in a way that's usable to the community. And so that really interested me, and I sent one of my staff members to take the research training courses that were being offered. But my advisory role now started to include CTSA, and what they were doing, I was included from the day they cut the ribbon on the community office at 390 Fort Washington Avenue, where Alejandra is primarily based. And I became visible in a research world in the way that I was already visible in the funding world of the city and in the advocacy world, city and statewide, because I don't really believe in doing things halfway. So all in. And so I was asked if I would be willing to be a consultant on a research project about the barriers to research within Columbia University. I thought that was really interesting because they had already done a study a few years before on what they thought the barriers to research were in the community. And I said immediately, it's not the community that's the big problem here. It's the lack of respect of community from researchers. And so my point of view was heard, and I was asked to consult on that research project. So that's the NIH Partners in Research grant that was jointly shared between Columbia University and the Dominican Women's Development Center, in which I was a consultant researcher and learned how to do something about research, which really had not been my field at all. And so I thought that was pretty interesting. And now I became visible with the School of Public Health mailman. And so a researcher there reached out to me and said, I want to do a research project on healthy homes for seniors in Washington Heights and Inwood. Would you be interested in being a co-PI? And my mom didn't raise any foolish children. I said, what's a co-PI? What am I responsible for? And how far do I have to go to be a co-PI? And why do I care? And she actually knew something about equitable partnerships. Her name is Dr. Robin Gershon, and she currently teaches at NYU in their public health program. But at the time she was here at Columbia University. And so we became partners in the project. It was a 5-year project. We included students to do some of the direct interviewing and surveying of clients, going to their homes. And we also committed to action. Alejandra's talk about principles is so important there because our action was that where there were faults in the housing, we would work to help the participants in the study get the housing problems resolved. And because it was a HUD grant, our first target was NYCHA buildings, because HUD money could be used for NYCHA buildings to do the repairs and upgrades that were needed. And we compiled a lot of resources for other kinds of problems. And we spoke to superintendents and we worked with home health aides to teach them what to look for. Most obvious things being overloaded outlets, vermin in the house. I mean, what are the things that are going on in our homes here in New York all the time that people are just ignoring, or somebody is living in the living room with only one light bulb. How could they possibly be safe and prevent falls if there's not enough light in the living room? And so it was a very productive product. We actually came out with a survey that could be done by any layperson as to home health hazards. And I thought, okay, maybe I can learn something about research. And, you know, being full of myself, the next thing that happened was I was reached out to regarding diabetes in the community by an acquaintance of mine from the United Hospital Fund, who wanted to do a project on community-based approaches to diabetes. And so I put together a consortium of community partners, because I'm always the community partner, guys. No matter what title I have, my interest is in the community, and that's how I see myself. And so we put together this project with 5 senior centers and a nursing home in Washington Heights and Inwood, where we provided support programs for people with diabetes, exercise programs, and people had a way to know where to go. If the doctor said you've got diabetes and you've got to change your diet and your lifestyle, it's really a hard thing to do on your own. And it's way easier to do in community and self-help groups, support groups, learning to move better, learning to eat proportionally differently. It's not really different kinds of food, it's mostly different proportions of food. And so I had a huge learning curve on diabetes, and I brought my expertise in working with community and knowing how to engage community. And so my friends in the CTSA said, you really should be a project lead. Right, Alejandra? And they told me about research opportunities with PCORI, which is the Patient-Centered Outcome Research Institute, created out of the Affordable Care Act to help community become stakeholders in health issues. And so I applied for and got funded to research metabolic syndrome. I put together a really wonderful steering committee. And in the end of the day, the seniors really didn't care about metabolic syndrome. For those of you who don't know what it is, it's the intersectionality of obesity, diabetes, hypertension, and high cholesterol, which really lead to that combination really lead to very bad health outcomes. And so I thought it was important, being full of myself. And the seniors said, I'm sorry, honey, but we're not interested in going further on that project. We're interested in falls prevention. And so we reapplied to PCORI to do capacity building in evidence-based dissemination of findings on falls prevention. We conducted that project until May of 2021. It was really successful, way more successful than I could have imagined, in the interest, in the need, and in the approach of involving seniors, involving community-based organizations, involving government, and involving researchers together to sit at a table once a month for 24 months and really hash out what was needed. And as a result of that, we created a CPR-based approach to promote falls prevention for older adults. And you see all the community partners with their little logos down on the bottom of that poster. Because the issue was that senior centers across the city run falls prevention programs and nobody knows. If I had said to you at the beginning of this conversation, who knows that senior centers run falls prevention programs, who would have raised their hand? Alejandra would have, but I'm not sure who else would have. And so we were all excited about this falls prevention project, and then COVID hit. We continued to meet throughout COVID virtually and by telephone, literally bringing our material to the seniors involved in the project in their homes so that they could participate fully in our meetings. They were totally motivated. We also had a community advisory group separate from the steering committee who talked about approaches to talking to seniors about why they should avoid falling and where they could get further information. We ended up presenting it in a conference, which was what we did not really want to do. And so I approached the Fan Fox and Leslie R. Samuels Foundation and said, through COVID, we discovered that our seniors do not have internet capability, at least not in my community. We had to reach out to them for 18 months by phone. And you know, phones come and go in a poor community. And we did our best, but it was not great. And so we asked Fan Fox Foundation to provide $40,000 in seed money to create a TV show about health issues being faced by older adults, with our priority being disseminating information on falls prevention. We received the grant in July 1st. We are in the midst of developing our first episode on falls prevention, which will be broadcast late this year, because it's about change. It's about us as a community coming together with researchers to foster change. Alejandra.
Okay, thanks, Fern. So in following or in keeping with CBPR methodology and principles, we wanted to make sure that this health education, health promotion project had a role for basically the target audience of this show. So we convened a consumer advisory board of older adults, and they are determining what are the topics that we are going to showcase on this show. And also helping us identify what aspects, for example, of COVID that we want to continue to address, because that now with the boosters and now there are shots that will be available for children, and we know that older adults play a key role in the care of their grandchildren, and so this information is also relevant to them. And so going back to principle number 9 about sustainability of CBPR projects, this current project through promoting health and health information through this TV series builds on the prior project and will allow us to continue now to inform our community of older adults about the importance of preventing falls and minimizing the risk of falling. And again, this builds on the target community having identified that falls prevention was a health priority for them. It continues to engage them and have a seat at the table for them to really steer the subject matter in the way that this is going to be showcased on this television series. And to reflect our community, we actually, our consumer advisory board, it is 10 members. However, the 10 members are split up into 2 groups. So we have an English speaking group and a Spanish speaking group in acknowledgement of the diversity in language within our community. So these are just screenshots of actually of our opening credits for the episode. So we'll be, over the next year, we'll be producing 6 28-minute episodes to air on the Manhattan Neighborhood Network. And it's called Vibrant, a show about living your best age in New York City. And our host is the very own Fern Hertzberg, and we'll be talking about different aspects of falls prevention, because falls is about balance. It's about looking at risks within our homes, but also having to do with vision and even what we eat. So it's actually a complex topic that we will address over the 6 episodes. And in the interest of time, I'll quickly just mention that we will evaluate this health promotion intervention to assess change in knowledge and activation among viewers to see if they implement the recommendations that we will cover. And I'll just quickly also mention that for us, it's key that the show be health literate, be culturally sensitive, and also linguistically. So we're taking into account all of those key issues. And so just quickly.
It is a bilingual show. I just wanted to say point blank that it's a bilingual show and not necessarily closed captions. People will be speaking Spanish as well as English. Yeah.
So I think we've run out of time, and I just quickly wanted to mention the Community-Based Participatory Research Scholars and Awards Program at our Columbia CTSA. Fern is a co-instructor of this class along with Dr. Joyce Moonhoward at NYU. And I invite everyone on today's call to reach out to us for more information if you'd like to participate. It is a capacity building program that includes a course, 10-session course on community engaged research. And you do it actually in partnership with a Columbia researcher. And after the course, there is a competitive pilot funding opportunity to look at a topic, again, a health priority within the community that you serve. So please visit us online. We also have our off-campus space called Columbia Community Partnership for Health, and or give us a call. I've also included Fern's email and my email should you have any questions about the CPPR program or any of the projects that we discussed today. Thank you so much.
I thank both of you so very much. Thank you.
Lula, before you introduce Natasha, there was one question in the chat.
Okay, go right
Dr.
ahead.
Hicks said, how do seniors view the movie? There's a community public service station they tune into view. She missed this part.
Oh, okay. So it'll be actually in 2 different ways. So Manhattan Neighborhood Network will actually assign us a date and time. And so we'll be able to promote the show. The show won't be live, it'll be pre-recorded, but we're hoping we'll get the same day and time so that we can just more easily promote it and people can continue to tune back in for all of the 6 shows. Once the show airs, Manhattan Neighborhood Network actually posts it in their YouTube page. And so other older adults will be, anyone really, it doesn't have to be obviously older adults, but anyone can actually access the show on the YouTube channel.
Wow, thank you so much, Dr. Alejandro and Dr. Hicks. That was a great question because I was wondering where I should watch it as well. Thank you so very much. And thank you, Fran. And thank you for being involved and being a leader from the community and inspiring so many others. So I thank both of you so very much. And thank you
Thank
for
you.
coming.
Thank you for the invitation.
I will invite some more. Thank you. Now we will have Natasha Ashley. She holds a lengthy experience in nutrition, stemming from being a public health nutritionist, supervisor, director of dietary, registered dietitian in Florida, then continuing in New York, where she has followed to be a clinical dietitian at St. Barnabas Hospital, and now the regional nutrition coordinator at Cornell University Cooperative Extension. She's highly skilled. She is a very effective speaker, and she's doing some very, very interesting and dynamic work in developing an app. So the next voice that you will hear will be Natasha Ashley. Thank you so much, Natasha, and we're looking forward to hearing you. Thank you.
Thanks, Lulume. Wonderful introduction. I appreciate it. Good afternoon, everyone. My name is Natasha Ashley, and I am going to get straight into the presentation where we'll talk about nutrition and health and research. So I will share my screen. Okay, are we okay? Everybody can see my screen?
Yes, I see your screen.
Okay, wonderful. Okay, so let's first talk about the Nutrition and Health Program. So the Nutrition and Health Program is based from Cornell University and the College of Human Ecology at Cornell University. And we have a program called Cornell University Cooperative Extension in New York City. There are different cooperative extension programs in New York, and this is based on the New York City region. So there are different programs within the New York City region: hydroponics, aquaponics, 4-H, youth development, family and youth development, and also nutrition and health. And we are also a part of the Expanded Food and Nutrition Education Program, also called FNEP, where we have different curricula that we use to educate our participants. One is Eating Smart, Being Active, which is more based on eating healthy and also physical activity. Choose Health, Food, Fun, and Fitness. We call it CHIF, and that is the youth curricula. And also Healthy Children, Healthy Families, which is also a nutrition education based curriculum, but it focuses a little bit more on parenting, and I'll discuss that a little bit later. So what is FNEP? It is a federally funded nutrition and health program supporting nutritional participants of low-income families. And it's based from a land grant, and we are a part of a land grant university. That's what Cornell University is. There are other land grant universities across the United States. So for example, in Florida, it's the University of Florida. In Pennsylvania, it's UPenn. So we have our land grant from Cornell University. And in our program, we have peer educators, participants who actually are now educators. So they come from the community. They're able to speak to those who are from the community as well because they know it best. And we train them for months on nutrition education. And also we have very much so interactive sessions that support improved behaviors, things like food safety, food prep, food resource management, and different type of topics. So it can help with our program success. And we've had lots of longitudinal studies here that show that these new behaviors are maintained throughout generations. So we've had lots of educators who taught grandparents and also parents and youth in our youth programs. And it also fosters lasting change. So it's not only that we are just touching upon these different topics for these sessions, it happens for a long time, right? So we have usually 6 to 8 week sessions once a week, and it doesn't just go for those 6 to 8 weeks. It's shown that parents and youth actually take these behaviors and they use it for a lifetime. Here's some data that we've had. This is from pre-pandemic. The total number of participants was 60,000 total family members. almost 250,000 total program graduates. So out of all of the program participants, 82% of them graduate. That means that they have taken 6 of 8 lessons, and they get a nice Cornell certificate at the end if they are graduates. The total youth participants are about 57,000, excuse me. Total youth groups are about almost 3,500. Here's some data specifically for New York City. The adult participants are there. Again, program graduates, 81% in New York City. And also for our adult participants, if you can see the racial background, about 63%, more than half are Hispanic and Latino. So we have lots of educators who speak Spanish. We also have educators who speak Bengali and Haitian Creole, Mandarin, Cantonese, Taiwanese, lots of languages. So if anyone needs any nutrition education in different language, we have it here. So 18% Black or African American, 15% Asian, 4% white, and 1% Indian, Native Alaskan. So at the beginning and the end of our workshops, we have our participants to fill out a questionnaire. So in this questionnaire, you can see we have questions that are saying, how many times a day do you eat fruit? How many times a day do you eat vegetables? What kinds of vegetables? How many times a day have you had the red or green vegetables, red or orange vegetables, dark green leafy vegetables? Do you drink milk? So there are many more questions as well. And so what we're able to do is kind of gauge and see where you are before the workshop begins or once it starts. And then you take the questionnaire at the end as well. And so that'll let us know if you maybe started at maybe 1 vegetable a day and now you've ended on 3 vegetables a day. We can see the impact that we have. Not only do we have this questionnaire, we also have a 24-hour recall where our participants go in and we have a form that they fill out what they consume in the last 24 hours. We input that information into our data system and we're able to give them a diagnostic report where they can see what their calories are, how it matches up to the recommendations based on the dietary guidelines for Americans. So for example, we may have a participant who is consuming maybe 1,800 calories and the recommended amount is 2,000 calories a day. Maybe they only have a little bit of grains that they're consuming and we have the exact amount of grains that they should be consuming a day, saturated fat, physical activity, so on and so forth. So it's a really good and really great way for participants to see what they're eating at that time and what the recommended amount is compared to other Americans. So from this behavior summary, we're able to get information for all of our participants, and this is some of the information that we receive. So this says 76% of our participants show improvements in 1 or more food resource management practices. So things like cutting coupons, right? Making a list to try and save money when you're grocery shopping. 78% of participants showed improvements in 1 or more food safety practices. So things like making sure you're having different cutting boards when you're cutting fruits and vegetables compared to meats, being sure that you're not thawing food for more than 2 hours outside of the refrigerator. 79% of participants showed improvements in 1 or more physical activity behaviors, maybe increasing their physical activity to 2 times a week from 1 time a week. And 91% of participants showed improvements in 1 or more diet quality indicators. And that's again, consuming more dark green leafy vegetables, consuming more whole grains, things of that nature. And this is a snapshot of FNEP in New York City. So you can see where the red dots are. That's where we go and educate. We go to different agencies. So it's mainly schools, also Head Start programs, adult learning facilities, churches. We're at food pantries a lot now. So we reach far and wide in all of the different boroughs, and you can see where we reach, right? So you can also see, so for example, it's not the amount of dots, the red dots are not that many in New York and Manhattan, I should say, because of the income level. So we focus on lower income levels. So now we're going to just focus on our randomized control trial that was done about 4 or 5 years ago called Healthy Children, Healthy Families, Parents Making a Difference. So this curriculum fully integrates parenting and nutrition education. So it's mostly parenting, as I said before, and it does have some nutrition education intertwined. And it's shown to be a feasible and engaging, acceptable for our participants and also for our staff. So what the study did is it aimed to provide research tested evidence of healthy children, healthy families effectiveness so it can be used for other programs in the nation. So here's the poster. Don't worry, you don't have to squint too much. I'm going to show it to you step by step what our poster is and what we presented from this trial. So the first portion of it, we talk about the curriculum, key modifiable behaviors that influence the child's weight as what we focus on, and also the parental influence in preschool years. So the focus in this specific randomized control trial is for parents who have preschool age children. Some of the interventions include knowledge, skills, and attitudes for parents to influence their child's behavior. And so this was developed and tested in collaboration with our parenting extension educators. So those educators that I mentioned before that were a part of the community that are now educators, they were a part of this as well. And so there are different objectives here to determine our impacts on low-income parents enrolled in the FNET program, and also to investigate the parents' retention of the changes in those parenting practices, to see how their diet quality and physical activity has changed for themselves and also for their child. So we had almost 400 parents that were involved from 11 Head Start programs in New York City, and they were split up into two groups, an immediate education group and also a delayed education groups. And these were further divided into English and Spanish speaking groups. The study design was a randomized control design and was carried out over 3 periods. So if you see down here at the bottom under methods, there's a little table here, and you can see how the trial was brought out. So at baseline, there was one group that got education right from the beginning. So they got immediate healthy children, healthy family education, and then there was a follow-up for 18 weeks. The next group had the delayed education, and they were the control. So they didn't have any education at first. Then they had a shorter amount of education with a shorter amount of follow-up. So here are some of the outcomes. Some adult outcomes were improved overall diet quality, increased consumption of fruits and vegetables, decreased amount of regular soda and sweetened beverages, and adults in both groups increased their physical activity, which is wonderful. Some of the children's outcomes were improved overall diet quality, increased consumption of fruit and vegetables, lower levels of soda consumption, and higher levels of physical activity as well. And some of the parenting outcomes were increased frequency of letting their children decide how much food they should be consuming, because that's what we are trying to do, make sure that our children are making informed and well-behaved decisions for themselves while presenting choices, and also high scores for the number of days of the week they ate with their children. So some of the impacts were that the graduates of the Healthy Children, Healthy Family reported significant improvements in overall diet quality for both themselves and for their kids. And this information was retained over time, and that this is an effective program in both English and Spanish to develop parenting skills and support healthy behavior for their families. So we do currently use this program, as I mentioned before, and it has been dispersed to other programs around the country. So now let's talk about the app. So I have helped to create an app along with the Clinical and Translational Science Center. So to get into the app, there was a bit of background. So as Lula May said, I worked for many clinical settings in long-term care facilities and hospitals and dialysis center. And specifically in the dialysis center, I've gotten many patients who asked, what can I eat? You know, so the dialysis, the renal diet is very restrictive. So there's a specific amount of fluids they can consume. Same thing goes for sodium and potassium. So they would get frustrated and ask me, so what is it that I can eat then? It seems like I can't eat anything. So it kind of made me think, well, I really want to have something for my patients that's very simple so that they understand when they get to the limit, to the amount where they're consuming maybe a little bit too much, or when they can have a little bit more. So that's a little bit of the background on how I came up with this app. And I thought of it being something as simple as red, yellow, and green, like the stoplight, right? And so we are currently the CTSC was seeking ideas and partnerships from the community on making apps. And so I just happened to tell them my idea. And now we are more than 18 months along in the journey and just kind of fine tuning what the app is. And so how does this translate into the community? It's a simple two-step process to get the information you need, right? So in the beginning, when you first start with the app, you add your height, your weight, if you're male or female, if you're diabetic and non-diabetic. And later on, once we continue to develop the app, we're going to add other parameters on there, add other health conditions such as high cholesterol, heart disease, renal failure as well, because some of these are associated with nutrition. Once you enter this information into your phone, into the app, an equation is suggested for your micronutrients and your macronutrients for the day. So basically all you do is you scan whatever food you have, you flip your food over, you have a little scanner thing back there, you point your phone, you scan it, and you're able to see if you should or essentially should not be consuming these foods based on what your health condition is. And it's as simple as red, green, and yellow. So here I have a demonstration of video that I have taken of my phone, and I'm going to play it. So this is the app here. So you can see I am scanning my food. Just these are some chia seeds. And so you can see once you scan it, it has the amount on here. You have organic chia seeds, you have the serving sizes, you have the calories. You can go a little bit deeper and see what else it is that you can consume or are consuming, the calories, the fat, saturated fat, carbs, protein, sodium. And also at the bottom, you have the ingredients too. Sorry for my New York noises in the background. You can go a little bit more in depth and see what the actual amount is, the percentage of carbs, protein, and fat, and add that to your log. And so once we go back, we can add more foods to our logs. And so we're adding some Tostitos chips on here. And so we have the serving size. So once you start to increase your serving size, you can see that the calories and the sodium start to increase. So as you can see, the green is starting to increase a bit more and more. And you can see the calories are getting to be a bit much. That's where we have the stoplight where you can see how much you are consuming. So you can see, again, the calories, the amount, once you go in a little bit deeper. I chose 5 servings of these foods here. And I see that I'm lagging a little bit. I'm gonna maybe stop my video. Hope you guys can still hear me. And so this is the amount of calories. If I chose 5 servings, it's 862 calories here. And then that's added to my log for the day. And so if I go back and I consume, or if I scan, I'm sorry, some whole grain snacks on here, then you see there are 2 options. So it can ask you if you want to choose the one at the top or the one at the bottom. So you can choose either one depending on which one you would like. And so once you click on the number of servings, you can see again that it's starting to increase. So now it's yellow. It's like, wait, you're doing too much now. And then it gets to red where it's like, okay, that's enough. That's too much. So I do like that it's so simple. You're just able to plug in the number of servings that you're actually going to consume, and you can see red, green, or yellow if you're doing well or not so well. Again, at the bottom, once you put in the number of servings, you can see that. You can see the ingredients at the bottom too, if you need to check on those. And then you can kind of go back and have that in your log for the day. And again, 10 servings is a bit much. That's 2,272 calories. But if that floats your boat, okay, that kind of logs into all the other foods that you've been having as well. Okay, so let's keep going. I'm going to start my video and see how that goes. Okay. So in summary, we are in the beta phase of this project, kind of reaching towards the end, okay? So we're hoping to release it sometime this year, at the end of the year. I know we're getting close to the end of the year, or towards the beginning of next year. So we need some more users. We need some more scans to make sure our data analysis and our food analysis is right. And then we'll be able to release it into the world. So I want you all to help. I'm sure that we will be able to give you this link here, so you'll be able to download the app and just go ahead and scan everything. Okay, so you don't have to have diabetes to use this. It's good for people with diabetes, but if you put in non-diabetic, it's going to give you the recommendations for a person without diabetes. Okay, so I'm sure that we'll be giving the app the link out for the app, so just keep on scanning, and that will help us out a lot. And thank you so much, everyone.
Thank you,
Thank you,
Natasha. I was
Natasha.
muted. Agnes, do we have any questions?
I don't see any yet. Felix says great app, congrats.
Thanks so much.
Well, thank you so much. Maybe is there any of our students who would like to use the app to try to add to help Natasha gather more information?
What I'm going to do, Hula May, is send out an updated link, an active link, and then hopefully you can send it out to everyone so they can download it on their phones and use the app.
Sounds like a great plan.
Yeah,
Thank
I will
you so
send
much,
it out.
Natasha.
It was funny because last week we had someone else from the class talk about how they had so many apps, and I was like, oh, next week we're going to mention another one. So
Another intriguing app. Yes. But this one has immediate payoff and immediate benefits. So
Yes,
thank
yes.
you so much, Natasha.
Thank you.
And I thank everyone for tuning in today and for joining us for this session of the Community Research Academy. If you have no questions, then we're looking forward to talking with you next week.
I just want to say thank you. That was a very rapid and enlightening and beautiful presentation. I'd like that app. I'd like to know more about that.
Absolutely. I'll make sure to send the link, and you click on it. I'll give my information out as well. I'm sure you have hopefully my email address. So if you have any questions about it, you can definitely feel free and contact me.
Okay.
Dr. Phillips, the presentations today were beautiful and very informative. Thank you very much. Just try to take my mind off things that I was thinking about here, going through my morning period. But thank the presenters. They were very, very, very good.
Good.
One of the things I have,
it warms my heart. Go ahead.
Question I have, as a parent, I'm a parent of an adult, but I think that the whole idea of nutrition, even for me as an adult, really gets kind of different in the 20th, latter part of the 21st century. I grew up sitting down at the table with whoever was whatever family member was there. Basically, my mom, dad, no dad, my mom. And meals were served, compared to everything being rushed on a table, drive by, go by, take out, snack out. McDonald's, I have to admit, was my go-to, and God knows how unnutritious it might have been. And I just look at this whole issue regarding those without food compared to those with food, and that somehow the responsibility of nutrition rests on the adult's behavior, because we serve the meals, we provide the meals. I think there needs to be a greater push on guilting us or advising us, not when you don't have the resources, but sometimes we do have the resources, we just don't want to use them. I don't even like to cook anymore, and I'm so glad I don't have any grandchildren, because I guess I'd be feeding them. But it's changed now. Food is accessible, yet it's inaccessible by our attitude, by our lifestyle, by our attitude towards food, about food. And I just see it as a problem still, but it's with the adults.
No, I absolutely agree with you. Thanks, Deborah, for that. But I think we live in a society, in a world now where everything is quick and easy, right? So if we don't have it right now, then we don't really want it. So when we have fast food restaurants, even when we have things like Uber Eats, maybe we'll wait 30 minutes for it, but we're not cooking it, right? So we'll be able to do something else in those 30 minutes and still not have to cook and have our food kind of quick and easy and right away. But I think what we're doing here in the nutrition and health program is showing that we need to get back to the basics, because what's happening is quick and easy is affecting us, right? So we're having kids with high cholesterol, with diabetes. We're having higher rates of cancer because some nutrition can affect some forms of cancer. So we have to try and get back to the basics and realize that we need to do things now in order to affect our future.
And may I make a suggestion?
Sure.
I think if we all get back to that plant-based diet, because there are restaurants that really serve plant-based meals. So we have no excuse. People say, "Oh, I cannot cook plant-based meals," and they have all kind of excuses. But there are restaurants that do provide plant-based meals.
Oh, absolutely. We have lots of restaurants especially in New York City, we have a restaurant every half a block or more than that, right? And so plant-based has been shown to lower weight, decrease obesity, like decrease heart disease. So plant-based is something that we want to try and increase in our community, and not just, kind of easing people into it. I think some people get a little bit worried about only having plant-based or only being vegan or vegetarian, but start small. Start with maybe one meal and then having one day, and try and increase it if you can. Start, take little baby steps so that we can have a plant-based diet and also having more whole foods, right? So less processed foods. The less processed foods, the better. So I always give the example of having a whole orange instead of having orange juice, or having like an orange drink, or like, orange, whatever it is, kind of stuff that they have. So just trying to get back to the whole food is also much healthier too. So there are lots of different steps that we can take to make us healthier.
Folks do complain about the protein because they don't have the meats and the whatever. They don't have enough protein, but the beans have more protein than meats.
Oh yeah, there are lots of plant-based proteins out there. So I think we just have to be a little bit more, just get more information so that we're well equipped to educate ourselves and make behavioral changes.
Thank you very much.
Absolutely. And also, I'm sorry, I just wanted to give a little plug for our FNET program, our nutrition and health program. So if you know anyone who are parents, and also we have senior programs too and youth, you can reach out to me as well. We give nutrition and health education programs for free. We do them virtually as well. So we're doing a lot of virtual workshops now kind of slowly going back in person. So if you are looking for a nutrition and health program where we talk about things like food safety, plan, shop, and save, increasing your grains and fruits and vegetables, please reach out to me. I have so many educators who are willing and waiting to educate our community.
How many weeks is your senior nutrition program?
So it varies. So our focus isn't seniors, it's usually parents. So for seniors, we've done just a one-time event. We've done 4 or 5. Right now I have some who are educating for the Department of the Aging in New York City, and they're doing an 8-week program. So it varies. It's up to whoever the agency is or whatever the participant wants.
Oh, okay. Thank you.
Excuse me.
That sounds amazing.
How can schools help? Because I remember when I taught, it drove me crazy to see those red drinks come in. And when I was a staff developer in the various elementary schools, those red drinks come out of a kid's pack with the Cheetos. Parents give money for snacks, but it's not the proper ones. How do we work with neighborhood bodegas, parents? Because the New York City Department of Consumer Affairs has a program where people go around and use kids to buy Lucy's, and then once the person sells them the Lucy's, aha, gotcha, you get fined. I mean, we need some red juice fines or something, some Cheeto fines, all the wrong foods in the morning.
Yeah, so there have been a couple of studies. One person named Tashara Leak, she has conducted a study in Brooklyn, I believe, with some bodegas where they're giving out healthy foods. They get a specific amount of money back for serving those healthy foods. When we get on campus at different schools, we have something called the Healthy Meeting Challenge, so that when we have PTA meetings and things of that nature, that we're serving healthier foods, not just bagels and pizza and juice and soda. I feel like we think that whenever we have a meeting or a party, it needs to be a pizza party, and whenever it's something in the morning, it has to be muffins and bagels and juice, and it doesn't have to be that way. So it's also up to the principals and the people who are the heads of the schools too, to not have that type of food in their schools. We've definitely gone to some schools and they're like, we do not have vending machines. We do not serve those types of foods. So we try and partner with them as well to get some healthy foods in there. It's a challenge, but we're trying to get it off and make sure that we're having healthier children bit by bit. But it is a challenge.
Thank you.
Absolutely.
Can you put the name of that person who did I'm in Brooklyn. And
Yes.
I work with the CB4 and there's an Youth and Education Committee. I'd like to share that information with them. So can you put that in the chat?
Can you put your email address in the chat and I'll connect you directly to her?
Okay.
I will also send everybody Natasha's email if they want to reach out to her. I know someone in the, Michael said that he would be happy to share this information with his dialysis patients.
Oh, yes.
So yeah, we got a lot of connections going on.
This sounds wonderful. I'm excited. Thank you.
Okay, so for any further questions, anybody can just email me. I will be uploading the video today and then sending it out. I would also be sending out last week's video. I know I didn't get to send week 5's, but if anybody has any question, please feel free to reach out.
I have a comment to make about the previous slot. Dr. Aguirre, may I go back to that? Because I was composing it in my head at that time.
Yes, of course.
I was just thinking when we talked about the presentation and equity in healthcare, and I said COVID has made those who observe become the observed, those statisticians, and those who analyze the data become the statistic, and allow those who have been ignored to get to the head of the line, that the rich could not buy themselves from the virus, and the virus leveled the playing field, and for once everyone had to start at the same place. Nothing was withheld. The virus created an interconnectivity between class, race, gender, sexuality, and economic class. That's what this virus has done. The invisible are now seen. The ignored are now heard. Because you have to treat everyone with this virus. You can no longer just have a class of people, the rich who can afford to buy the anecdote. It doesn't work that way. This is a leveler. And if anything this virus has done, other than wreak disaster, is have you develop a framework of thinking and philosophy about life and how you see people and how healthcare has to see people, because we're not taking care of the president. We're taking care of grandma. We're taking care of your in-law. We're taking care of the neighbor across the street, the one you don't even talk to, who now has to come to your door perhaps and offer you something, your children something to eat while you're recovering in a hospital. This virus is more than just a virus. It's a leveler.
Mm-hmm. Mm-hmm. Absolutely. It has, I think, changed all of us in very, I think my point here is what I'm trying to say is that I think it's up to us to make sure that we don't go back to pre-COVID. Mm-hmm. And that we remain visible and heard. And because I think everyone is eager to get back to normal. Right. But by doing so, we also run the risk that we will just go back to just being on the side. And so we need to make sure that we build on the changes in the last 2 years. brought on by COVID, but brought on by other social phenomena that has gone on at the same time, like Black Lives Matter, changes to institutions like police brutality. All of it is interconnected. The amount of poverty and hunger that we've seen in the last 2 years as a result of this pandemic.
But before the virus was pointing to, so there were benefits of those who could do without. So we had, in my era, the AIDS virus, just those gay people or those Haitians, to the Ebola recently. I said AIDS, Ebola, those Africans. So we're no longer doing those people because we're now all maybe one day one of those people. And that's, and you're right. For us to go back would be a movie. You know, it would be a typical movie, you know, that, you know, happy and I can go back to my life being selfish, mean, you know, uncaring, snobbish. There's a humility that this virus, you know, places under those who fear, who suffer, who worry, who work. One of the things we do with this photo
novela.
Yeah, no, photo novela is just take a look around us and we see how we're not going to return. Those stores aren't coming back. Those people are still out of work. Never mind the fact you decided you didn't want to clean houses anymore because, you know, of COVID. No, they're not there for you anymore. So we need to rethink now those resources that are going to be required when the virus does ebb and our attention is no longer on our health, but on reality, survival.
And I think next week you might have, or your next session, Dr. Elizabeth Cohen discussing photo voice, which I think is a great subject matter to follow this one. And the points that you brought up, Dr. Hicks. It's another social action technique that's very powerful and participatory and equitable because it's accessible to everyone. So it's a great topic to follow this one, to build on.
Well, the government can't ignore now because it's in government's face, in government's hands, you know, so we have to be responsive and participate, you know. Fortunately, something great has happened as a result of this disaster. My booster shot is going to be in my home. That wasn't, we didn't think that earlier in the year, but those who couldn't leave their home or and able to get to their home had to go in crutches and wheelchair to the site. So they're coming to my home and they're going to give my son his booster shot as well. So it's not even about who you are, it's about where you are. She asked, who else is in your household that would require the shot? Thank you, government, for that.
Right. Finally, the power dynamics are shifting, and instead of expecting people to come, then it's public entities, government entities going to where people are. And I'll just remind everyone that November 2nd is on Tuesday. We have to go out and vote.
That's right.
So true, so true. I thank all of you so very much. I thank each and every one of you for your participation in the program today. We're looking forward to doing this again. Oh, go right ahead. Very, very good. I'm glad. So I will see all of the students next week, and the presenters, I thank you, and we will be sending out requests for your participation very soon. Thank you all very, very much, and have a wonderful weekend.
You too. Thank you.
Good day.
Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.